Grant, I think I'll begin now anyways. Welcome everyone to today's Journal Club on the gold standard internal target volume in hepatocellular carcinoma. So today we are joined by Dr. Anil Gupta, who is a consultant radiation oncologist in the Cure Cancer Clinic in Noida, India. Dr. Gupta is a highly respected oncologist, as educational journey includes an MBBS from the Ramaya Medical College in Bangalore, followed by an MD from the Postgraduate Institute of Medical Education and Research in Chandigarh. He has further refined his expertise through senior residencies, and he has an interest in proton and particle therapy with an observership at the Heidelberg Ion Therapy Center in Germany. He has many publications, and today he will be discussing one of the publications that was published in the Journal of Applied Clinical Medical Physics, and the link to read this paper is available on BeamHub. So Dr. Gupta's study aims to determine which specialty image set most closely matches an all-phase ITV contour on a synchronized contrast enhanced 4D CT. So this is a really interesting study, and it is amazing to have Dr. Gupta with us today to present this idea and the work behind this publication. So any questions can be left in the chat box, and we can get to them at the end of the presentation. And without further ado, I'll pass you on to Dr. Gupta.
Okay. Thank you. Good evening and good morning to all. So I'll be starting my presentation. So the topic is gold standard ITV in hepatocellular carcinoma. So this study was conducted in Institute of Liver and Biliary Sciences in Delhi. It is a monospecialty institute which deals in mainly liver and pancreas and gallbladders. So in this department, in this hospital, we mainly had 90 to 95% of patients we had were based on hepatobiliary. So the equipments at our center was, we had a Versa HT and Panic CT was GE Discovery PET CT. Motion management system was ANSI respiratory gating system, and treatment planning system was Monaco V5. Although for this study, we conducted the study on MiP-MinIP-AvgIP trial version. So here you can see the setup of our patient on Versa HT machine. So the most important question, why this research question? Why there was need for a question on ITV? Which ITV should we do?
Sorry, Dr. Gupta, I don't think it has moved on to the next slide.
Okay. Has it come?
I'm just on the first slide. That's the only one I can see. Yeah, I can see the different slides now. Sorry.
Okay.
Perfect. Thank you.
So, okay. Is it visible right now?
Yeah, it's visible now. I can see the slide.
And okay.
Thank you.
Fine. So the most important question is why this research question? So as I already explained, our hospital was the monospecialty hospital dealing with most like 90% of our patients were liver cancer patients. So as we know that 90% of patients were hepatobiliary patients and 7 out of 10 patients were of HCC. So the challenges we faced in delineation of HCC was we were unable to identify HCC lesion in delayed phase, only planning 4D planning CT, which is a standard at that time. And there was difficulty in registration of diagnostic arterial enhancing phase CT with a planning CT. And the traditional way of delineating all the phases of respiratory phase was time consuming. And there is a peculiar feature of liver cancer is that it is only visible in arterial enhancing phase or delayed phase. So these two combined, in these two contrast scans, we can identify liver cancer. So coming to the next slide. So the solution to first two problems. The first two problem was unable to identify HCC lesion in delayed phase only, and difficulty in registration of diagnostic arterial enhancing phase CT without planning CT was resolved by this research study, in which we made a technique of 40 CT simulation with synchronized intravenous contrast injection in HCC patients. So for this, we had to delve into hardcore contrast kinetics. And we came up with this synchronized intravenous contrast which had 40 arterial enhancing, 40 portal, and delayed 40 scans. And we also came up with the formula T scan delay is equal to T peak minus L naught by detector coverage cross senior duration in seconds to time contrast with scan. As we know that 40 CT scan normally takes almost 35 to 40 seconds as compared to normal CT scan, normal 3D CT scan, which takes almost 3 to 4 seconds. So we have to time the contrast in such a way that we can see the arterial enhancement when the scanner is on the lever. Then only we can time it and we can synchronize it. So this formula really works and this gives the results. So here you can see our results also. So in the first image, you can see there is a single scan. In this, you can see all the images, like these are the faces of the CT scan, 40 CT, 0, 10, 20, 30, 40, 60, 90. So here you can see a very good, very nice arterial enhancement. Here it is, the tumor is very easily visible. And in the second video, you can see all the phases of respiratory CT scans, in which you can see the delayed. There is a hypo enhancement with the delayed scans. So, like in this arterial phase, we see different characteristics of the liver cancer, and in this delayed, we are able to see different characteristics of liver cancer. And the portal phase, as we see that we also have a portal phase. In this portal phase, we can see the portal venous thrombosis, which is very common in liver cancers. I think there is some problem in this moment.
Can you not click on
Okay,
the next slide?
is it fine?
It's still on the slide with the two.
Okay, so I have moved on, but it is not moving, right?
Oh, it's moved on now. It's probably just a little
Okay.
bit delayed, but thanks.
Okay, so here you can see it is the first image. First image is a synchronized 4D CT contrast, arterial contrast scan. And the second image is a diagnostic CT scan. And if you see, like you can see a very good quality as equal to the diagnostic arterial phase. And in the third, you can see the delayed. In the third, you can see a synchronized 4D CT delayed washout. And here is the non-contrast diagnostic scan. So if we only use non-contrast diagnostic CT scan, we cannot see the tumor. We cannot differentiate tumor from the normal liver. But if we use arterial enhancement, we can differentiate the normal liver from tumor. And if we add delayed phase, we can verify it is an HCC tumor. So, but with this technique, we are able to get the 4D CT synchronized arterial and delayed phase. So here you can see. And another interesting thing is that the previous techniques, sometimes they only used a very small area of the liver. But in this, we are able to get the whole scans from here to here. And we can easily contour all the organ at risk also. And we can easily see all the values of the organ at risk also. So, so at present, and even back then also, we did this in 2018, 2019. So SBRT is not a mainstream. So radiation treatment, even in our institute at that time also, radiation treatment was kept at the footnote of HCC treatment. So only they sent cases when other treatments failed, tumor progressed, or when there was portal vein thrombosis. So we had only one chance and we had to prove it. So with this, we'll start our introduction to this study. So as we know that accurate target definition is crucial in stereotactic ablative body radiotherapy. And in HCC, it becomes more challenging as adjoining healthy liver is radiosensitive. CT density is similar to that of adjoining healthy liver. Tumor motion is non-linear and So here you can see, is the video visible? Can you see the video?
It's still on the slide with the scans. Did you move on to another one?
Hello.
You
So
might need
I think video is not working, right?
it hasn't moved on to the next one, I don't think. I think you need to scroll down and click on to the next. Yeah, we can see you moving through the slides now.
Okay, so I will not full screen it because it is we are not able to say it properly.
Yeah.
So I need to revise a bit before. So let me get back again. So as per now also, even back then 5 years back also, SBRT is not mainstream for HCC. Radiation treatment is kept at the footnote of HCC treatment. And even in our institute and even worldwide also, they only send cases when other treatment failed or tumor progressed or when there was portal vein thrombosis. So with this, we start our introduction. So as we know that accurate target definition is crucial in stereotactic ablative body radiotherapy. It becomes even more challenging for SCC as adjoining healthy liver is radiosensitive, CT density is similar to that of adjoining healthy liver, and tumor motion is linear, non-linear, and has hysteresis. So here you can see the motion of liver. You can see here that liver move with respiration, and this is the motion. So to accommodate this motion, we create this ITV, this which is known as internal target volume, and this we are able to accommodate all the motion of the liver tumor, and the uh, area over GTV is known as internal margin. So after ITV, we have to give one PTV volume for uncertain. Sure. So for this, the methodology was we took 10 patients who had undergone SABR treatment from 2018 to 2020, and the patient had unresectable HCC, which were not suitable for RFA and breath hold. Tumor was very visible on CT scan. Patients had a regular breathing pattern and had no allergy to contrast. And they also gave informed consent with normal liver volume of more than 700 cc with ECOG performance status of 1 to 2, 0 to 1. So we took the synchronized 40 CT, a technique which we developed and which I have already explained. The parameters evaluated were target motion analysis, volume of ITVs, and dissimilarity index. The ITV which we drawn and compared were ITV all phase, in which we took all the 10 phases of the respiratory cycle from the normal inspiration to the normal expiration. So these are the 10 phases. So and combining this was our ITV all phase. The second ITV was ITV of two phase, in which we took maximum inspiratory and maximum expiratory phase. The third one were the spatial ITV maximum intensity projection, and the ITV minimum intensity projection, and ITV average IP was also taken, and the sixth one ITV, in which we combine ITV and MIP and average IP. So all these were compared for dissimilarity index. So what is dissimilarity index? It is the spatial overlap between two segmentations A and B region. So it is a spatial overlap between two segmentation A and B target regions, and it as defined as DSI for A and B is 2A intersecting B upon A plus B, where this sign is an intersection. So, for example, this one is A. This is the first ITV, and which is considered as gold standard, for example, and this is the second ITV. And what area is the overlapping? So that will be known as dissimilarity index. So in this case, for example, A is 100 cc, the B is 120 cc, and the A overlapping B is 50 cc. So DSI will be 2 cross 50 upon 100 plus 120, which is 0.45. And Another example we take, like in this A is this and B is this. Here DSI will be 1. And another example, A is this and B is this. Here DSI will be 0. Now coming to results. So here we can see that ITV all phase was compared with ITV 2 phase, and the DSI was 0.87. And the second scenario, we compared ITV all phase with uh, ITV controlled by MIP, and the DSI was 0.75. The third one was all phase, which was considered gold standard, was compared with average IP, and the DSI was zero point 0.8. The fourth scenario, it was compared with mini IP, and DSI was 0.66. The fifth scenario, it was compared with ITV2M. The DSI was 0.83. And the last scenario, ITV all phase was compared with ITV3M, and the DSI was 0.86. So dye similarity index, which was the best in ITV2 phase, it was 0.87, and the second is 0.86. And it was least in mini IP. So here DSA was 0.66. So if we have to choose among all, which is the best one? So which would we choose? So since DSI of two phase is the maximum, it is 0.87. So if we have to choose which is the closest to ITV all phase, it is ITV two phase. And if we have to reject, ITV mini IP, which has a DSI of 0.66. And the second best is ITV of 3M. But the thing was that uh, statistically all ITV iterations had a significant difference with ITV all phase. That means we cannot choose statistically. We cannot take ITV two phase as similar to ITV all phase. So if you go to target motion analysis, the the maximum tumor motion was superior inferior. It was almost 1.2 centimeter, and followed by anterior posterior, and followed by mediolateral. So if we see because of diaphragm movement, the maximum motion is in the superior inferior, and the least is in the mediolateral. If we see ITV volumes, we can see that if you go by mean, so ITV with a mean is 116 in the gold standard of ITV all phase, and the closest is ITV2M, or we can say ITV3M. It is the closest one. And the second most closest is ITV2M. So in this regard also, based on the volume, ITV2M and ITV3M are the closest one. So this is here you can also see by graph. Here you can see that ITV all phase, the closest is ITV3M and ITV2M. And in this DSI also you can see this is the DSC of all phase is standard. It is gold standard. It is 1, and the closest is ITV 2 phase, followed by ITV 3M. And now coming to so based on this, what challenges were addressed? Since because of 4D CD synchronized contrast, we were able to manage tumor motion, and it also improved delineation of arterial and delayed phase scan. And with ITV all phase, there is accurate target delineation. So what is the clinical implication of this? So with using all phase ITV, it ensures accurate target delineation, reducing treatment errors. Combined approaches may be inferior. And we use this for our patients, and there was clinical translation of improvement in our results also. So this we published in 2021. So here we can see that there was a very good biochemical response of more than 50% in almost 72% of patients, and less than 50% had only 8 patients had less than 50% decrease in tumor markers, and there was in 3 months there was almost 45% complete reduction, complete response, radiological response. And we have compared our study data with other authors, and here you can see that our patient had the maximum, almost maximum tumor size, as close to Chopra et al. From Tata. They had also 9.8 centimeter tumor size. We had 8.6, and all the patient in our study had 100% thrombosis, and RT dose were lower side in our patients, and the local control was 95%. So even with smaller doses, lower doses, we had almost 95% local control. So which is more than all other authors in this. And only okay. So so I was telling that we the results of our techniques had a clinical role also, and there was a clinical improvement in our study results also. So here we can see that we had a good response in the liver tumors. Uh, in biochemically, we had more than 50% decrease in tumor from baseline in almost 72.5% patients in 1 month, and 80% in 3 months. Like 23 out of 29 patients had more than 50% decrease in tumor marker response. And if we compare our results with other authors' result, in our patient we had tumor size of 8.6 centimeter. It is a huge tumor. All the patient had portal venous thrombosis. The dose were relatively lesser, and the local control we got was 95%, and the complete response was seen in 35% patients. And if we compare with all other others, we had the best local control. But since all these studies were done in the beginning of the departments, the department was getting established. With these techniques and studies, we developed much more confidence, and at present, we give higher doses. So we give doses of BD more than 100. So normally it is almost 50 gray in 5 fractions. So the limitation of the studies, this is a small sample size study, which was retrospective in nature, and this is limited by the technique specifically. The technique we have used is not used in other areas also. Like we have used synchronized contrast enhanced 4D CT, and the technique which is normally used worldwide is they take only the delayed scan, and in the delayed scan we can also use MIP, also ITV MIP. But nevertheless, even we claim that the all phase ITV is the gold standard for SABR in HCC due to its super accuracy. Any specialty image sets and the combined approaches, although provide alternatives, and it may or may not help, and also require further validation. So what is the future direction for this? We need larger studies to validate our results, and there is a need for exploring advanced image techniques to improve ITV accuracy. So thank you.
Thank you. That was
With this, I would like to end my presentation.
yes, perfect. If anyone has any questions, like I said, they can add them into the chat box, or if they want to say them out loud, they can use their microphone too. We'll just give people a few minutes in case they have any questions. I think a few people are typing, so we'll just give them a minute. There's a question that just came in there saying, are you using any motion management device? So any like abdo compressions or anything during this?
So we are using abdominal compression also. Initially, we used a lot, but we found one default. We found one fault with this. With abdominal compression, we are able to reduce anterior posterior motion. But with reducing anterior posterior motion, there is also increase in superior inferior motion. So we found this abdominal compression as like of no use. It honestly reduces anterior posterior but increases superior inferior motion.
That's really interesting. I didn't know that it increases the superior inferior motion as well.
Because the reason is that you are normally breathing, and if we are not able to breathe anterior posteriorly, there will be more of superior inferior motion. So unless and until we cannot hold the breath, so there is no use of this. So we initially used, but we did lot of experiments. Although we did not publish it, we did lot of experiments and we had lot of debates. So our ultimate understanding was it is of no use.
That's really interesting. So you would prefer like deep inspiration breath hold techniques rather than anything like this?
We would prefer gating or breath hold, and if the tumor motion is less than 1 centimeter, and we would go for motion encompassing technique also, in which all phase ITV is used,
Yes.
but never abdominal compression.
Okay. Good to know. I hope that answers your question, Mahmoud. And there's no other questions as of yet in the chat box, so we'll just give it another minute
Sure.
see if anything comes through. Okay, we have another question that came through there as well. So the question says, in your practice, what is the primary data set you use for planning?
Very interesting thing. So primary data set which we use is average IP for OAR contouring and for planning. And all other like we use all phases, like we take 10 phases of respiration and we use that for contouring, and then we copy those data to average IP dataset.
So do you delineate the 10 phases? Is that what you're saying?
Yes.
Delineate.
Yes, it is cumbersome. It takes a lot of time. But if you have MIM-Maestro system, so it is easier in that one. But we use Monaco system. So we had Monaco system, and we have to manually contour in all phases. So that is the reason we went for this study. Like, can we reduce our time by just contouring two phases or other intensity projection phases? But our results were negative on this.
Okay. Thank you for that. Okay, Mahmoud typed in his question, so I can read it out loud here. So he's asking that he's saying that he's concerned about the IGRT quality. Do you think that average CT will be easy to match to cone beam CT images?
Very interesting question. In Versa HT, we had a 4D CBCT. The CBCT we had was 4D quality. So we used to do 4D CBCT and you used to match. Had certain problems, but we were able to manage.
Okay, that's very interesting, and I think he's actually heading over to question now, so we'll see if anything else comes through.
Okay. So there is a debate that Excel IBH breath hold data set is much better for IGRT in image fusion. Um, Let me think. But like the question here is like what as in physics.
Sorry, you can probably answer again, Dr. Gupta.
So so I am not aware of this debate that Excel breath hold is better for IGRT. As per our physicist, they told us to take primary data set as the average IP. As according to them, they were of the opinion that with average IP we have a better representation of dosimetry, and image fusion was better as per them. So I'm not aware of this debate. It may exhale breath hold may be better. I'm not sure about this. So what is the practice nowadays? So people use exhale breath hold to combine, or
Yes, can you hear me now?
Yes, we can hear you. Yeah.
Yeah, that's good. Okay, that's good. So yeah, it was like, yeah, we in our practice now we are using the breath hold, the exhale breath hold as our primary data set. So we contour the ITV for all phases, and yeah, it's on the and we use the exhale breath hold as our primary data set. So we do the planning there and export this to the LINAC, and then we use it for the
but
IGRT. The idea
yeah,
here is it's better to, because the average makes the image is quite hazy. So for soft tissue, it's not easy to well observe the soft tissue targets and organs as well. So it will be hazy. So you can't rely on it, use it during your IGRT as well.
here I have a
Yeah.
question in this. So since we are not doing breath hold technique, we are doing motion encompassing technique in the technique we have explained. So in which there is free breathing, patient is in the free breathing.
Yeah,
So
it's
if we are
it's the patient's treated on free breathing as well. That's the trick here. So we use the breath hold exhale, and but the patient's treated on the free breathing. And the idea of
okay,
having this exhale breath hold, the idea of having breath exhale, yeah, is that when the patient, yeah, spend most of time at this phase. So even during the free breathing. So that's the idea of using this phase only, and it's like it's you yeah, it's like an extra scan during the CT. So we are using 3D, 4D CT, and breath hold exhale.
but in breath hold, so how do you make the patient breath hold and exhale? It is difficult actually.
You can we are using our SGRT, kind of SGRT. So you can see
Okay.
the
So,
phases, and yeah, and
so
use it.
yeah, we also did some patient with NEBH. NEBH is normal expiratory breath hold. So in that case, we used to do, but otherwise in free breathing, we never did this. But yeah, I will think about this. Like, is it better? It may be better because there is no artifact. I can understand. With exhale
Yeah,
breath hold, there will be less artifacts.
it's less
And with
artifacts,
average,
and yeah, and this is the
with,
closest phase to the CBCT actually. So that's the idea of
yeah,
using
it
it.
may be true. Yeah, it is
Yeah,
new to me. I'll try
yeah,
to read about this. Yeah, thank you.
yeah, no problem at all.
But like average IP was also used. Like one is exhale breath hold, and can what is the second best? What do you think?
Actually, the average it will be the second one, because yeah, this could be the average one would be. But actually, we are using the average only for the lung cancer, lung lesions. But for any soft tissue, we used to use the breath hold. If the patient can tolerate the breath hold, yeah, we decided in that case how the quality of image, maybe average, maybe the 3D free breathing.
Okay,
That would be the yeah, how would be yeah
okay.
our
Thank you.
primary data set. But yeah, definitely our ITV is, yeah, we use for DCT for, yeah, all phases, contoured on all phases.
ITV all spaces. Yeah.
Yeah. So that's the point. One more question about the HCC actually. Yeah. Do you think about having some fiducial markers to be inserted and trying to assess the motion or something like that? Have you tried it
Yes, yes,
something?
yes. So
Yeah.
we also had cyber knife. So initially we had Versa
Yeah.
HD, then
Mm.
we bought CyberKnife, and we used to do fiducial marking a lot. So obviously, I think it is a better technique. Only problem with fiducial marking is like fiducial implant. So
Yes.
whenever
Yeah.
you try fiducial implant, so there should be a geometry of, but we were unable to find that geometry. Like we had a lot of problem in this. So sometimes we were able to, like, our target was to implant three fiducials, three gold fiducials, and maximum time we were able to only use two fiducials. The third fiducial was either very far, either it is unaligned. So with cyber we had this problem, but it is, I think, better technique. No,
Yeah. Yeah. And did you try fiducial on Linux itself, or you haven't? You didn't so far.
fiducial thing,
On Linux. Yeah. Yeah. You mentioned that you are using it for CyberKnife.
cyber knife. Yeah,
Yeah,
we are using for cyber knife.
but you didn't try using it with the Linux-based SPRT or something like that. You haven't. Because my idea here is,
With cyber knife, we use a technique of tracking. So
yeah,
we
I
did
know that.
tracking with it.
Yeah, yeah,
But
yeah.
using gold fiducials for matching is not a good idea
Yeah.
because there is a lot of migration. There is a lot of
Yes.
migration of fiducials.
Yeah.
And
Yeah.
second, we have CT scan. We used to do CBCT. We had CBCT. We used to do soft tissue matching. Soft tissue matching is always better than fiducial matching. In
Yes.
CyberKnife, we had APID scans were there, which was like 2D imaging, and that obviously fiducial plays a very important role.
Yeah. Yeah. Because
And
actually, in our practice, we start using the triggered imaging techniques on Varian, which is kind of trying to mimic what's in CyberKnife. So the idea is you are tracking during the treatment. It's tracking the fiducial, and it's not tracking. It's kind of gating. So if the fiducial
so
within,
how can you, like, how do you track with variant which
yeah, it's
machine and
on. Yeah, we have Variant Edge, which is kind of STX, and this technique is called triggered imaging, and the idea is
yes, yes, yes,
you're collecting KV images during the treatment. So it's the same as CyberKnife, the same idea of
yes, yes,
CyberKnife.
yes. In 2B we had this option. True,
Yeah,
it is there. We were
yeah,
planning. We I have worked in TrueBeam also, but we were planning to use this technique. So we have not used, but I am aware of this. Yes, we can do.
yeah,
You're right.
yeah. And actually, so my opinion about, because I have some debates about, yeah, this. I'm sorry if I'm asking a lot of questions if someone else needs to ask, but the last question is, do you think having it's better to use this kind of CBCT first and then tracking the fiducial or something like that, and this makes the cyberknives quite inferior, because in cyberknife you're only tracking the target. You don't see how far your organ at risk. You don't see what's the behavior of that. So you just focusing on the tumor, but you don't care about if there's any change in organ at risk, especially for abdomen. If you have like bowel is behavior is changed or something, that the bowel during treatment comes to closer to the BTV or something like that. So that makes it's quite a, yeah. So do you think that scenario of having a kind of CBCT first and then tracking the fiducial, so just to have a good vision for everything?
Yes, true. So, like, CyberKnife is the most fascinating machine I have worked in. So, I am a big fan of CyberKnife. Undoubtedly, it's an amazing
Me too,
technique.
actually. Yeah. Yeah.
Yeah, you're very right that, yeah, because of fiducial migration, it can be a problem. And so, what we can do to avoid this is we can take an CT scan, diagnostic CT scan, to check if there is fiducial migration or not. And the second thing, uh, the beauty of CyberKnife is it is able to identify fiducial migration even by 1 millimeter also, even less than 1 millimeter. It is able to identify fiducial migration. So So we can take in planning like diagnostic city before to check fiducial migration, and we can do the soft tissue matching also. Then we can use CyberKnife. But if there is no fiducial migration, and if fiducials are like placed properly, so there is no better machine than CyberKnife dosimetrically also, since we can have we have lot of freedom in like placing beams, and we can do tracking. Yeah, it is amazing.
Perfect. Thank you so much, Dr. Gupta. I think that was the end of the question from Mahmoud, if he has any others. And there's no other questions in the chat box, but that was really interesting. And the conversations there were really interesting to listen in on as well, hearing different sides and different takes. But I think if anyone has any other questions, they can ask them now. Otherwise, we're probably able to wrap it up.
So one thing I would like to discuss is like I was there from 2017 to 2021 in this institute, and so I went to this conference. They had an international level conference for liver cancer this year, almost 1 month back, and I was very happy to see that SBRT is given lot of importance. So previously, SBRT was not spoken of. Now, in liver cancer, SBRT is given a lot of importance. So, thank you.
Thank you so much. That was really interesting, and I think everyone will want to take a read of the study now. Like I said, it's available on Beam Hub, so everyone can have a look at it afterwards. But yeah, thank you so much for joining us, Dr. Gupta. That was really interesting.
Thank you.
And thank you.